Good morning, everyone. So today I am presenting this topic, unique issues in liver transplantation for biliary atresia. So I will present my talk under these headings: indications and young adults with biliary atresia, weightless mortality, role of PELT, primary versus post-Kassai, surgical issues, anesthetist issues, and about nutrition, and very briefly about a few of the post-transplant complications. So biliary atresia, as we all know, is a progressive fibro-obliterative disease of the intra and extrahepatic bile ducts of infants, and it affects 1 in 8,000 to 12,000 live births and is the commonest cause of neonatal cholestasis. So these are the three different types of biliary atresia, and unfortunately the uncorrectable type, that is type 3, where the porta is also where the atresia is at the level of the porta, is the commonest, which is 90%, and the corrective surgery, as we are all aware, is Kassai portoenterostomy. So what are the indications for liver transplant for biliary atresia? So to understand this, we should understand the natural history of post Kassai surgery. So this is the data with the compilation from most of the series. So unsuccessful Kassai is around 30 to 40%, and successful, that is bilirubin less than 1 milligram per deciliter at 3 or 6 months. So when the Kassai is totally unsuccessful, these children rapidly decompensate with rapid progressive portal hypertension, with variceal bleed, infections, and they require transplant within infancy. With successful Kassai, there may be again two outcomes. The patients may have recurrent cholangitis, so again they will have progressive portal hypertension and subsequently decompensation, and they require transplantation at a variable age from 2 to 15 years. And those patients who have infrequent cholangitis, they have slowly progressive portal hypertension without any decompensation and may survive into adulthood. And the series say that this number ranges between 15 to 30%. So this is again a slide on the natural history of successful Kassai portoenterostomy in biliary atresia, that is bilirubin less than 1 milligram per deciliter. So various outcomes are shown here. So first of all is recurrent cholangitis, which is seen in 30 to 40% or up to 60% in some of the series. So they have decompensation, rapidly progressive portal hypertension, require early transplantation within 1 to 2 years of age. Some of the patients have very severe refractory cholangitis in early infancy. So they may have infections, multi-organ failure, and of these patients, they have portal hypertension, and subsequently a proportion may have late transplant, and the rate is around 20 to 30%. A small proportion, and this series I will discuss later, may have acute on chronic liver failure like presentation as per the Cliff definition, and these children also have infections, multi-organ failure, and a high transplant weightless mortality up to 25%. A significant number develop hepatopulmonary syndrome, and there is a link between hepatopulmonary syndrome and portal hypertension. And lastly, those patients who have infrequent or no cholangitis at all, they have slowly progressive portal hypertension, and around 60 to 70% of this infrequent or no cholangitis may survive into adulthood, and this proportion of overall successful Kassai is around 20 to 30%. So these are the events in the long term after successful Kassai: cholangitis, portal hypertension, hepatopulmonary syndrome, and decompensation. So what are the transplant indications in the absence of jaundice? So this study has shown that even if the patients are anictric, they may have portal hypertension up to 53% and uncontrolled variceal bleed in around 1/4 of the patients, and 43% may have intractable cholangitis, and growth failure again is a relative indication in a small proportion of the patients. So bilirubin predicts portal hypertension. So as the bilirubin increases, so the grade of the varices increases along with red colored signs and presence of gastric varices. And bilirubin also predicts the transplant-free survival. So when the bilirubin is less than 1 milligram per deciliter, these children may survive for 5 years or up to 10 years with their native liver in around 60% of the patients. And if the bilirubin value is more than 1 milligram per deciliter or more than 20 micromole per liter, so then they have less transplant-free survival, only up to 15 to 20% as per this study, up to 2 years of from the Kassai. So what happened when these patients bleed with variceal bleed? So when the bilirubin, so that also depends on the level of the bilirubin. So if the bilirubin is less than or equal to 4, so then there is 80% survival at 4 years. But if the bilirubin goes beyond 10 milligram per deciliter, so then there is very poor survival, just 50% at 4 months. And the odds of death with variceal bleed and higher bilirubin more than 10 milligram per deciliter is 12, and with 4 to 10 milligram per deciliter the odds of death is around 7. So hepatic artery resistive index progressively increases when with the development of with the progression of fibrosis and cirrhosis in children with biliary atresia, and a cutoff has been proposed that when the value comes when approaches 1, so then it means that they are heading towards need for liver transplant. So the HARI should be evaluated in children post Kassai, and this should be tested every 2 to 3 months. So what about when they reach adolescence or adulthood? So there are large series from in adults and adolescents who are surviving beyond 10 years or 25 years with their native liver, and survival with native liver has been shown to be ranging from 23 to 76%. So they have cholangitis in around 1/4 to 2/3 of the cases. Portal hypertension is almost universal from 33 to 95%. Majority are cirrhotics. Variceal bleed is seen in up to 1/3. Hepatolithiasis is seen in up to 10%, and some of them may have a picture on MRCP similar to secondary sclerosing cholangitis. So overall, 1 in 4 or 5 cases become long-term survivors with their native liver with good physical and mental development. So what are the predictors of long-term survival with the native liver beyond 10 years or beyond 15 years? So these predictors are biliary flow after the Kassai portoenterostomy, age at Kassai portoenterostomy, cholangitis episodes, whether these cholangitis episodes are properly treated or not, and late disappearance of jaundice. So this is a large series from King's. So where 111 children, so this proportion was 28% who survived beyond 16 years of age, and beyond 16 years of age they predicted whether they require transplant or not, and need for liver transplantation was found to be associated with development of portal hypertension, varices, and late cholangitis. So this is another series, almost the similar group of patients from King's, just published recently, 2021. So various adult prognostic scores like MELD sodium, UK MELD score, and also the Mayo primary sclerosing cholangitis score. So this Mayo primary sclerosing cholangitis score is used because biliary atresia is a disease which is almost similar to adult primary sclerosing cholangitis, and these all scores were found to be very with a very good area under ROC curves of more than 0.85. So these all scores were good predictors for predicting their need for liver transplant. So it should be considered that when these children are transitioned to adult side, so this is again from King's, 36 adults transplanted, and 14 have been sent to the transplant by the adult team and 22 by the pediatric team. So when they are transferred to adult and then they get the liver, so they have to wait longer. So there was a significant difference, 10 versus 5.8 months in comparison to when they are referred for transplant from the pediatric side, and also from the adult team side. So there was more frequently required ICU stay. So this indicates that the transitional care is important and it can improve the outcome of these patients. So what about weightless mortality? So this table summarizes the weightless mortality and also transplant-free survival. So transplant-free survival ranges from 27 to 64% at various time points, 2 to 4 and 5 years or 10 years. And the weightless mortality, as we can see here, ranges from 0 to 20%. So this is a large series published recently, Journal of Pediatrics, where 2,700 children who were waiting liver transplant for biliary atresia. So the weightless mortality was 5.2%, and the predictors of mortality were increasing bilirubin, portal vein thrombosis, ventilator dependence, and presence of ascites. So this is again data from US, where it has been shown that infants under 1 year of age, they have higher weightless mortality, which is almost 2 to 3 times higher than the older age groups. What about acute and chronic liver failure? So this has been again a data from King's, where they classified categorized these children who presented as ACLF as per their CLIF Cliff. So for definition, so as per the Cliff definition of acute on chronic liver failure, so 99 biliary atresia were followed up, and almost 20, that is 1/5, developed acute on chronic liver failure like presentation, and their mortality rate was almost 5 times, 20% versus 4%. And predictors of acute on chronic liver failure were found to be higher bilirubin at 3 months post Kassai, high INR at 6 months post Kassai, and higher PELD at the time of listing. And in a majority of them, the precipitants for acute on chronic liver failure were either sepsis or presence of variceal bleed. So what about the transplant outcomes at different ages? So as I already said, that under 1 year, the infantile age group is actually the most vulnerable. So their transplant outcomes are also not very good. At 5 years, the transplant outcomes are the survival are 85% in comparison to the older children, which is almost around 90 to 94%. So whether these children should be considered too early or too late for transplant. So this is answered by this is one of the study from Italy, where 3 time periods were considered. So first time period was when the transplants were when the patients were in the DDLT wait list, and the institute has not yet started the LDLT program. So that was up till 2011. And then the second period was when the parents were given option for LDLT, and the third period was when early LDLT was offered. So so it was shown that the change in PELD was not that much significant when they were offered early LDLT. So DDLT versus LDLT when they compared, so LDLT obviously they have more of left lobe grafts and also left reduced grafts, and one important point to note here is they had less operative time, less chances of need of prosthetic closure, and also the duration of hospitalization was also less, although the figures here are comparable, 25.5 and 25.5, but there was a significant difference when we consider the whole when they consider the whole number of patients. So what about long-term outcome of adult to adult living donor liver transplantation? This study is a bit older, from Japan. They have shown that adults had higher intestinal perforation. So this is in contrast to the other studies where the infantile age group has been shown to be worse outcome, but adults, when they have gone beyond a certain stage of portal hypertension, so they also have higher chances of intestinal perforation, intra-abdominal bleeding necessitating laparotomy, and also bile leaks. And predictors of mortality were related to higher MELD and also risk of re-laparotomy. Actually, Japan has the lowest primary liver transplant rate also. So because they are they have early diagnosis and also Kassai potentoscopy, that is actually and the success of Kassai also is the highest in Japan. So coming to PELD score, so the PELD come into picture in February 2002. So this is a recent data from where they have shown that after the introduction of the PELD, so before 2002 and after 2002, so there has been significant improvement in their outcomes, and so around 96% versus 89% in terms of patient survival as well as graft survival. But higher PELD is known to be associated with more morbidity, more infectious complications. So this study has shown that when it goes beyond 14, so there is more morbidity, around 4 times more. And in this particular study, they have also shown that portal vein hypoplasia and undernutrition was also associated with the higher mortality. So this is an interesting review. So where they have shown that that younger children under 2 years of age, so they are even with the usage of PELD score, they have high weightless mortality when they are listed for transplant. So the mortality rate is up to 15%, and they suggested various things like we have to optimize the success of Kassai potentoscopy by early and timely diagnosis of biliary atresia, and early Kassai, antibiotics to treat the cholangitis, and aggressive nutritional management, and also to maximize the liver transplant options by using the left lobe, reduced grafts, split grafts, and also ABO incompatible liver transplant. So what about primary versus post Kassai transplant? So this is a nice review by Superina. So where various series have been reviewed. So this study shows that the primary liver transplantation rates range from 0.51% in Japan to around 11% in Germany. So on comparison of, so this is one of the largest series published in JAMA Surgery 2019 of 626 biliary atresia children. Half of them underwent Kassai and half of them were directly taken up for primary liver transplantation. And as we can see here, so there was infectious complications which were more in the salvage liver transplantation group. So in terms of sepsis, bacteremia and cholangitis in comparison to the primary liver transplant. So this is the data again from the same study, where they have shown that before 2002 and after 2002. So before 2002, the primary liver transplantation and the Kassai outcomes were almost comparable. So there was just a marginal difference. But after 2002, the primary liver transplant was significantly better in comparison to the Kassai portoenterostomy in terms of overall survival overall survival as well as with the survival with the native liver. After native liver after the Kassai. So and also they have derived that that total hazard for mortality after salvage liver transplantation was around 9 times in comparison to primary liver transplantation, where the hazard ratio was better, which was 0.19. So this is a meta-analysis of 14 studies where primary liver transplantation versus post-Kassai liver transplantation was compared, and of the 1500 patients, 76% received Kassai, and they have shown that it was comparable in terms of patient survival, graft survival and reoperation rate, but there was higher risk of post liver transplantation infection, almost 2 times in comparison to the with the post-Kassai liver transplantation in comparison to the primary liver transplant. So there are merits as well as demerits with primary liver transplant. The merits are there is absence of scarring, less adhesions, less blood loss and operative time and perforations. But demerits are they are younger age, so they are more risk of PTLD, donor availability issues. The surgeons have to use a reduced or hyper-reduced split grafts. With post-Kassai liver transplantation, the merit is in terms of cost. I will come to that study. And the demerits are again in terms of scarring, adhesions, portal vein hypoplasia due to repeated cholangitis, and also resistant organisms, more risk of infections. So this is a study which is published in Liver Transplantation this year. So cost effectiveness of primary liver transplantation versus post-Kassai in biliary atresia in United States using a Markov model analysis. Various different parameters were entered into the Markov model, like cost of Kassai portoenterostomy, cost of transplant, monthly cost after the Kassai and after liver transplantation, and also the risk of mortality after liver transplantation or after Kassai portoenterostomy. So they have found that with primary liver transplantation, the overall cost was almost 18 lakhs something dollars, which was higher in comparison to the post-Kassai liver transplantation. And also they derived that even if we consider 100% graft and patient survival in primary liver transplantation, then also the post-Kassai liver transplantation is more cost effective. So and also it was found that the post-Kassai is even cost effective even we consider late referrals beyond 90 days even if you do Kassai portoenterostomy. So what about briefly about surgical issues? So first thing is about the size. So what type of graft is used? So this study from Chicago, they have shown that around 40% received around 27% received the whole liver, 42% received the living related transplant, and 31% have a split or reduced transplant. So in this particular study of 2,100 biliary atresia transplants, around half of them were whole liver, 16% LDLT and 30% split liver transplant. It was shown that in the lighter children, means less than equal to 7 kg, the overall survival rates 5 and 10 years were superior for LDLT and the split liver transplants, whereas in the heavier children more than equal to 14 kg, the split liver transplantation was inferior in comparison to the whole liver and LDLT. And for under 7 kg weight children, the vascular complications as well as the retransplantation rate was more with the whole liver in comparison to the LDLT and the split liver transplantation. And also about the type of split, how do you split? So this is actually a purely surgical paper, so where the dissection was compared whether it is transhilar, that is classical through the segment 4 when you get only single duct, in comparison to transumbilical through the umbilical fissure and the plate where you may get 2 or more than 2 ducts. So the outcomes were found to be comparable. There was no increase in the biliary complication. So they suggested that the choice has to be based on the surgical expertise of the institute. about portal vein this thing atresia. So why there is portal vein atresia in biliary atresia infants? So there is intimal hyperplasia which has been shown in comparison to the explants, portal vein of the explants of non-biliary atresia CLD patients, and this intimal hyperplasia and hyperplasia of the atresia of the portal vein has been shown to be related to the cholangitis episodes, and also there is some humoral mechanism related to this portal vein atresia. So portal vein sclerosis. So various studies have determined the size. The portal vein size has been proposed as a cutoff of less than equal to 4 mm and a portal vein velocity of less than 11 centimeter per second, and with the increasing HARI, so there are more chances of need of portoplasty at the time of liver transplantation. So this is another study, again the same size has been derived, and presence of hepatophageal flow and HARI more than equal to 1 has been shown to be associated with more risk of portal vein thrombosis post liver transplant. So overall the portal vein complications are around 9 to 27% in terms of thrombosis or stenosis, and the reason is discrepancy in the size of the vessels, and also the portal vein sclerosis, if it is pre-transplant, if it is there, so then there is more chance of portal vein thrombosis post transplant. So how to handle this? So this is so as per the as I already said, when the size is less than equal to 4 mm, the interposition grafts have to be used, and also the collateral channels. So in a cyclic manner they have to be ligated, starting from the left gastric vein, splenorenal shunt, splenoretroperitoneal shunt, left paracolic gutter, and Treats ligament, right paracolic gutter. So everything has to be dissected and devascularized, and finally the splenorenal shunt should be also ligated via an anterior approach. So a few words about hepatic artery thrombosis. So this is again a large series of 3,800 pediatric liver transplants. Majority of these were biliary atresia. So the risk is around 7.4%, and the predictors are prolonged warm ischemia time, which is associated with higher risk of hepatic artery thrombosis, and there are certain good factors which can prevent hepatic artery thrombosis, like adolescents in comparison to the younger age group, they have less risk of hepatic artery thrombosis. Similarly, acute liver failure in comparison to biliary atresia has less risks. So biliary atresia has around 45% more risk of development of hepatic artery thrombosis, and also split, reduced or living donor grafts, again they have lesser risk of up to around 60% lesser than in comparison to the whole grafts. So hepatic artery thrombosis, so in this particular series, so various complications which are associated with the HAT are anastomotic and non-anastomotic biliary strictures, bile leak, biomas, biomas, cholangitis, and this is associated with a poor outcome in terms of graft failure and high 90-day mortality. So biliary complications range from 5 to 15%. It may or may not be associated with the vascular thrombosis or with or without. And so in this particular series, this series is from Taiwan, so where they have shown that the rate was around 3.4%, and they were managed with percutaneous biliary interventions. So from Japan, they actually proposed that usage of trans-anastomotic biliary tube at the time of transplant, which remains there for few days to weeks. So that is actually associated with less risk of biliary strictures in these infants. So what about primary versus delayed abdominal closure? So this is a large series from King's. 230 pediatric liver transplants, 76% underwent primary versus 24% had delayed closure. So the weight difference was different, not significant, but there was difference, 19.5 versus 14.8. So younger infants had delayed closure in comparison to the heavier infants, and ALF cases were more likely to have delayed abdominal closure than chronic liver disease. So this difference was around 42 versus 19%, but they found that there was no difference with regard to age or with regard to GRWR. Biliary atresia children were also equally distributed in primary versus delayed closure, and primary closure, what they found, had shorter length of stay, shorter ICU stay, and also shorter ventilation days. So they did not find any change in the GRWR, but they proposed that there are various determinants of closing of delayed closure, like higher GRWR And if the anteroposterior abdominal depth is actually that depends. If the anteroposterior abdominal depth is less and the graft is bigger, so then there may be difficulty in closing the abdomen, and also clamp the portal vein, so there is more risk of intestinal edema and graft preservation injury, which is again related to delayed abdominal closure. So how to avoid this thing? So this can be avoided, means in terms of, because if it is too tight, so then it can lead to abdominal compartment syndrome. So how to avoid this? By avoiding the compression of the new graft, and also careful selection of the GRWR which they proposed, which is possible in a DDLT setting with high volume centers. So if the child to donor weight comparison is almost 1:10, so then we can use left rectal segment. If it is 1:3, then left lobe. If it is 1:1.5, then right lobe should be used. So for LDLT, it has to be a reduced or hyper reduced grafts. So what about various anesthetist issues? So various issues briefly are small airway. There are in younger infants there is risk of increase in abdominal pressure and abdominal compartment syndrome. There may be associated heart defects like situs, ventricular septal or atrial septal defects. So these children require early tracheostomy, and also use of high flow nasal cannula and nasal CPAP, which can actually help these children in going into repeated desaturations, and also early mobilization and physiotherapy, that also helps in improving their outcomes post transplant. Another thing is cirrhotic cardiomyopathy, which has been shown in a large series from Texas, that it is seen up to 49% of infants with biliary atresia, depending on the left ventricular mass index. And this is again associated with risk of multi-organ failure, and with ventilator and vasopressor requirement, ICU, as well as hospital stay. So cirrhotic cardiomyopathy also should be looked up in infants who are going for transplant. So what about nutrition? So there are various series in literature. So just to show one of this series from Japan, where they have shown that younger infants under 1 year of age, they are actually more severely malnourished with poor weight for age and height for age Z scores, and they divided into whether they had body weight deficit or not. So this was associated with more of bacteremia and infective complications. And also the younger age groups were have more significantly smaller portal vein size, and subsequently they had more risk of portal vein complications and also greater blood loss. So and also in relation to the nutrition, so now the studies are coming up on sarcopenia as in adults. Now there are studies in sarcopenia in pediatric chronic liver disease patients, based on CT imaging, and they have shown that sarcopenia is present in up to 40% of the children, and it affects the post-transplant morbidity, ICU and hospital stay, and also infectious complications. Similarly, frailty also has been assessed from one of the center from Canada, Sick Kids Hospital, where frailty in just as similar to adults in terms of slowness, weakness, exhaustion, diminished physical activity and shrinkage, it has been shown to be presented in up to 46% of the children, and this is more with decompensated end-stage liver disease in comparison to the compensated liver disease. So how to manage the nutrition? So monitoring is basically based on triceps skin fold, mid-arm circumference, and also mid-arm muscle area. And so these children need adequate nutritional rehabilitation in terms of calories, 125 to 150% or even up to 180% of recommended dietary allowance, proteins up to 2 to 4 gram per kg per day. So by increasing the caloric density of feeds and giving continuous or bolus nasogastric feeds. So there is one study in literature where they have used TPN in biliary atresia children when they were transplanted at a median age of 10 months, and they showed that there was improvement in triceps skin fold and mid-arm circumference in around 60% of the patients, but obviously there were some line infections in these children. So lastly, few words about the younger infants with biliary atresia when they are transplanted. So they are more prone to this post-transplant lymphoproliferative disorders. So this is a large series published recently where the rate of post-transplant lymphoproliferative disorder is almost twice in comparison to adults. So 5.1% versus 2.3%, and it was also shown that children usually present earlier in comparison to adults, 14 months post-transplant versus 57 months, and almost half of the pediatric post-transplant lymphoproliferative disorders develop within a year of liver transplant. So in this particular series, so as we can see here, so age at PTLD, the median age was around 2.8 years, and biliary atresia again was the commonest etiology in 35 of these children. So for younger infants, we should be very careful about post-transplant lymphoproliferative disorder, and more than 95% of these are associated with EBV viremia. So lastly, we should, when these infants who are transplanted, when they grow up, they should be adequately and timely transitioned to adult hepatology team, and usually this transition should begin around 12 to 16 years of age, covering all the aspects like medical, psychological, educational, vocational, growth, and employment and independence. So everything should be considered. So finally, coming to the ILBS data, so this is means the overall the number of transplants which were done here are now 100. So 31 transplants were for biliary atresia, 20 were males, and their median age was 1.5 years. So from 6 months to 17 years. And from 2012 to 2016, we had 7 biliary atresia who were transplanted, and after that we had 24 biliary atresia who got the transplant, and 27 of them were living donor, and 4 were deceased donor liver transplantation. And of the living donor, 5 received their liver from their fathers, 21 from mother, and 1 from aunt. And out of these, 26 required vigorous nutritional rehabilitation with nasogastric feeds. And of the baseline characteristics, 8 of them were unoperated, and 23 had post Kassai liver transplant. And the cause of the indication, specifically in the post Kassai age group, was recurrent cholangitis in 16. Portal hypertension was almost universal; it was in 23 out of 23. Severe HPS in 2 of them, and decompensation in 20 of them. About the vascular complications, 2 had portal vein thrombosis, 3 had portal vein stenosis which required angioplasties, and 2 had hepatic artery thrombosis. So 3 had biliary complications in the terms of leak, collection, and bilomas. And rejection, I have to still analyze this data further, but rejections overall, 4 children had rejection, 2 were acute rejections, and 1 was late acute required ATG, and 1 had chronic rejection. So survival till last follow-up was 22, that was 71%, so 9 children died. There were 2 deaths in the DDLT, which was quite unfortunate, and in the LDLT setting, so there were 7 deaths. So finally, to summarize, I can say that biliary atresia children for transplant, so the first thing is they should be subjected to Kassai. So up till now, as per the current literature, we should not actually subject them for primary liver transplantation. But if we see the data from West as well as from the East, the proportion of primary liver transplantation is gradually increasing. So, and we should look up carefully the indications for transplantation in these children. It should not be too late and not too early. And this decision should be multidisciplinary transplant board, and they should be adequately optimized for nutrition, and the vascular anatomy and the plan should be clear before taking these children for transplant. And overall, I can say that outcomes of these infants who are going for transplant, that is improving worldwide with improvement in the surgical expertise. So finally, I thanks my department of pediatric hepatology, and so most